Moving on to the last section of this episode, it's about 3 new drug managing strategies, drug classes to lower risk of cardiovascular incident. 2 of them are drugs that you have, one for sure you've heard of. One, if you've been paying attention to us for any length of time, you know we've been talking a lot about them.
Mm-hmm.
Another one, unless you're a super nerd and you live in the world of cutting edge scientific breakthroughs, you haven't heard of it, but it's worth presenting at this time. We're very excited about all 3. And the first is statin therapy. Talk about an emotional topic.
Oh boy.
There are camps firmly rooted all over the place, whether it's the greatest thing that's ever happened and you need to put it in the water, to it's the most evil thing that's ever been created, to anywhere in between. There is a lot of emotion, confusion. There's a lot of noise around this topic. And I'm talking about drugs like Lipitor and Crestor, this class of medicine that is designed to lower cholesterol through the suppression of production. So it helps your liver produce less. What I want to specifically talk about statins is not whether it's good or bad for cholesterol, but that it's where the data is strongest on what it actually does to lower risk of cardiovascular disease. Because let's be clear, the only reason we care about cholesterol is its relationship to your risk for cardiovascular disease. So when we start talking about things outside of cardiovascular death, I'm not really sure where that conversation is going. And that goes beyond the scope of this talk. I'm not so interested in it lowering cholesterol, even though that is one of the benefits, especially if you have known disease.
Right.
The data is very clear that if you have established cardiovascular disease, you had a cardiac incident like a myocardial infarction, heart attack, the survival rates are much better if you get on a statin. One of the reasons that has become very clearly shown in the data is that statin therapy converts unstable plaques that rupture and cause heart attacks, to stabilized plaque. And although we would like to reduce plaque, the next best thing is to take plaque that's there and calm it down.
Right.
Turn it into rock hard, calcified stone. That stuff usually is considered low risk to rupture. It's the non-calcified stuff that's very dangerous. I have 4.5 times the amount of non-calcified plaque in my coronaries than I do calcified. That's a problem. And when I'm looking at greatest area of opportunity, the calcified stuff, the stuff that showed up on my calcium score, it's just there.
Yeah.
And it's unlikely to do anything in my future. What is far more likely to create problems is this non-calcified accumulation of plaque. And I know statins are very good at flipping it over to calcified. And so statin therapy really should be considered by anyone who has evidence of non-calcified plaque accumulating in your coronaries. And again, I'm not going to go into like LDL targets and all the, like, that's between you and your physician to figure out where the right goal and the right set points are for you. But with the Clearly study, we can now say, hey, is this statin therapy over a period of time working? Defined as, am I de-risking my future by increasing the amount of calcified plaque versus non-calcified plaque in my coronaries? And if you do that, that therapy is working. I think there are 3 major questions that come out of statin therapy. Number 1, can you slow down plaque formation? And the answer is yes. By lowering the amount of cholesterol, LDL that you're making, you will slow down the accumulation of LDL particles in your coronary arteries. Can you change the composition of a plaque from an unstable to stable? And like I've said, yes, absolutely. That's, in my eyes, that's its primary benefit, actually. We now have other tools that are way better at lowering cholesterol than statins. I'm interested in statin for the plaque composition changing. Can you reverse unstable plaque? I don't know. Instinctively, I think the answer is probably yes.
Mm-hmm.
I'm actively on that journey.
Yep.
Because I have so much non-calcified. I'm on a statin therapy that was very thoughtful and selective. I'm also on a therapy that I'm going to talk about in a little bit. I will report back next year on the 2024 update.
Good.
I think we should be able to reverse unstable plaque. But we'll see. There's some promising therapies. The next question is, can you reverse stable plaque? The answer is, I have no idea. And I'm not even convinced that really matters, because stable plaque is by definition stable.
Right.
So I'm not sure it would be worth pursuing that. You may create more harm than good. So I have no idea, but I'm not actively measuring that. I will be able to report back that if my calcium plaque, calcified plaque after my therapies have reduced, then I'll report on it. But I don't anticipate that being a thing. Basically, summarizing this first section is clearly has allowed me to take a different vantage point on my risk factors, which included having an elevated cholesterol profile. And now I can assign a strategic therapy and then measure downstream to see if it's working. And I'm very excited about being able to measure it.
That's awesome.
It is.
Yeah.
The scientist in me is very excited. The emotional human in me is very like, okay, fine. Okay, fine.
Well, and I think it's worth noting the good thing about the statins is they're very well tolerated overall. And
for the most part, yeah.
They're cheap, and there's lots of different options. So if one doesn't work, we can always switch it and just try another option. But yeah.
Yeah, well, it takes the religion off of lowering cholesterol and the religion on the thing that I'm trying to reverse, which is the unstable plaque.
Right.
And for me, that was a little freeing psychologically. How has this changed the way you're thinking about this in the patients that you're managing?
As far as statin therapy?
Yeah.
Oh, and this goes back to my weight loss days, where we would see severely obese people come through. We would put them on a protein sparing modified fast. Their lipid panels would be a mess. We weren't checking ApoB at all back then. And we would give them the promise of, hey, we could probably get you off your blood pressure medicine and your statin therapy. Wouldn't that be great? And now I'm like, maybe. And we just didn't have any further information to make good decisions. So now with Clearly, it's just so exciting that we have that that extra layer of knowledge to help. But I feel like I kind of was in the camp of anti-statin therapy for a long time. But now, knowing the mechanism of action in more detail, the research and the data behind how they operate, how they work, and then with the other class of drugs that we're going to talk about at the end here, my thinking has really changed.
Yeah.
And that it's not a bad thing to have to have a statin.
Yeah, I think it comes down to kind of all therapy and all the answer, should I or should I not fill in the blank to whatever the question is almost always it depends.
It depends, yeah.
And I think for a lot of people, free-thinking, intelligent adults in this world of information where everything is at your fingertips with the internet, and there's so much noise and conflicting information and really a lack of trusted, unbiased wisdom, people's default is to just freeze, and then we get kind of analysis paralysis, and we don't know where to trust, and we're really craving. We have information overload, but we're craving wisdom and insight.
Yeah.
And I just think, for me, the Clearly testing has been able to allow me to leapfrog over the religion of the statin debate and go right to, well, do you have heart disease? Yes or no?
Right.
And if you added statin therapy, there is a modality or a mechanism of action with statin therapy that has been shown to de-risk, which is converting unstable plaque to stable plaque, that we can actually measure, and I can manage what I can measure. So it just completely, like, using the iceberg analogy, it would be like the the captain of the Titanic, 12 hours early, if he would have just been told, hey, there's something, you could just avoid the whole thing.
Mm-hmm.
Like you don't have to go through the minefield of icebergs. You could avoid the whole thing if you have enough runway to make those adjustments.
Yeah.
And that's my hope, that people would hear this and say, man, we have tools. Should we identify some atherosclerotic changes? We have tools that can improve your risk downstream, and we have a way to measure the success of that therapy
Mm-hmm.
in a way that we never have before.
Mm-hmm.
So I think people should rethink statin therapy if they've had a anti-statin therapy thesis up until this point.
Agree.
The second class of medicines that we really need to be thinking about, I'm going to let you talk about. We spend tons of time talking about metabolic disease, obesity, obesogenic, insulin-resistant diabetes, those kind of things. What's the second class of medicines here?
The second class that we talk about are the GLP-1 agonists, and we've talked about these before on a podcast, but it's the semaglutide. The trade names are Ozempic and Wegovy.
Right.
Ozempic, FDA approved for the treatment of type 2 diabetes, and Wegovy for obesity.
Mm-hmm.
These are amazing drugs. We're not shy in introducing these or prescribing them to anybody with insulin resistance, metabolic disease, because metabolic disease is an accelerator of cardiovascular disease.
Correct.
And if you don't go on offense and delay this aggressively, it's a 1-to-1, right? So if you become diabetic, your increase for cardiovascular disease
it's a risk equivalent.
It's a risk equivalent, right?
Which means in English, it's the same as having heart disease.
Yep.
So, and the problem is, although hypertension and cholesterol also are accelerators of heart disease, metabolic disease like insulin resistance and diabetes, it also is an accelerator of that, but it's an accelerator of cancer. It's an accelerator of dementia, the other big killers.
Yep.
It's the ultimate gateway pathology that we have spent an obsessive amount of time getting a hold of, and I feel very confident about where we stand with that. But it's still one of our best tools that we have, and we're incredibly excited about it.
And people do generally well on these drugs.
It's pretty well tolerated.
It is a weekly injection. Some nausea, some GI side effects, but the appetite suppression is amazing, especially at the higher doses. The effects on insulin, blood sugar,
remarkable. Fatty liver, all of those things we've seen huge turnarounds in. Primary drawbacks, cost.
Yep.
It's still very expensive for most people, unless you happen to have diabetes and you have insurance that it's a preferred.
Yep.
Even if it is covered, the brand name is, at least at the time of this recording, generally unavailable, especially in the starting doses. Some of the cruising altitude doses, the bigger doses, seem to still be available. Hopefully the supply chain things will sort that out. And it's an injection.
Yeah.
And so these are the things to be considered, but all things considered, it is, again, I'd encourage people to think about it in terms of an investment in your health, and it's a very powerful. The other downside is it's still a relatively new medication. I mean, we're very optimistic, but we probably need a good 20 years of data before we know for certain the safety profile. But so far, it appears to be very well tolerated, very safe, and remarkably effective in the weight and weight-related disease world. The third class of medications, likely this will be the first time you've heard of this class. It's something called a PCSK9 inhibitor. It's a tongue twister. The primary drug on the market is called Repatha. I am actually taking Repatha. I started this specifically because of my ApoB particle number being too high. And I am again, back to the Titanic analogy, I am using a full force avoid the ice field altogether. I have enough evidence that has come into me in advance that there's an ice field in my future involving cardiovascular disease. And I now have the ability to measure the efficacy of my therapies. And now with this tool and the statin therapy and my blood pressure and the other things that I have done, I am looking to systematically go around and completely avoid and come out the other side free of the ice field.
Yeah.
And I will obviously be documenting this journey and be sharing it with people. I am very, very excited about this class, PCSK9 inhibitors. The mechanism of action is, so if statins work at the level of the liver to decrease production of the liver, the PCSK9 inhibitors upregulate the LDL cholesterol receptors in the liver to pull it out of the body. And some of the early reports, early data are showing within 30 days like a 70% reduction in particle number, which is fascinating. So if lowering cholesterol particle number can reverse soft plaque, I'll be here to report it, because I'm also going to be repeating my Clearly study in about a year. So stay tuned. But this is something, if you have familial hyperlipidemia, which is a genetic condition, this is the only condition that this medication will be paid for in most cases. The only other exception would be if you have wild dyslipidemia and you are resistant to all statin therapy. Most pharmaceutical companies are not going to pay for this. It's quite expensive. But again, might be worth the investment. So the big drawback is the cost. It's likely several $100s.
Are these relatively new as well?
Yeah, actually, I very first heard about them in 2015, 2016, and they were introduced specifically treating FH patients, familial hyperlipidemia. These patients have done nothing wrong, but they just have wildly high particle number, and every one of them, with no exception, ends up with early cardiovascular event, and their only risk factor is their ApoB particles are through the roof.
Yeah.
And this class of drug is annihilating their particle number and completely de-risking this genetic condition's risk for heart disease. And so it was unavailable to the mass. It was several $1,000s a month when it first came on. I've been paying attention to it. It's now somewhere in the, it depends, but $500-600 a month or something.
Wow.
Cost prohibitive for many. But stay tuned. If these things are effective and continue to get mass adoption, cost does come down. But you heard it here first.
Yeah.
Something to consider asking your primary doc if it's of interest to you.